one is also a generative model. So VAE stands for variational autoencoder, but we typically use it slightly different than the GANs. So we typically use it to identify the most important features, describing the underlying variants in the data, the embeddings. Then we can, of course, use whatever favorite data visualization tool we like. The above is actually a clustering of cancer cells. But beyond visualization, this enables us to start combining data in multimodal ways, and we'll come back to that. GNN stands for graph neural net. You've heard all about them. You're familiar with knowledge graphs, social networks. This is one way to operate on them. But I wanted to point out that molecules are also graphs. Graph neural nets enable us to preserve topological information connecting the different atoms, and this enables us to make better predictions about the properties of our molecules. On the bottom row, transformers. Many of us will have heard of BERT models for NLP, and that's important in itself for better harnessing biomedical literature. But you can also apply attention mechanisms to patient medical records, for example, and it's something we're exploring. Reinforcement learning learns the policy function, optimizes the system. The example I put on screen is from a paper where it's learned how to take treatment decisions to better optimize a patient's journey. But there's examples of it optimizing entire health systems as well. And the last example, I called it neural ODE, but in general, if you attend one of the main ML conferences like NeurIPS, you'll notice increasing interest in this combination of first principle physical models with machine learning models. And this enables you to have that flexibility of an ML system combined with the mechanistic scientific understanding of your experts have. And this can take the form of solution constraints, in this case PKPD modeling of patient metabolism and chemical reaction kinetics. And the final box I like to put up there is what's next. So what is that next groundbreaking development going to be? And I like to point out that I think that's the wrong question. I think the correct question is, so what? Yes, ML can do these very specific tasks, and they're impressive in their own right, but is this really going to deliver on the transformative potential of AI health? That is not an easy question, even for people who live and breathe all things data and digital. So how do we start to address it? So the first thing I want to stress is the point that pharma is hard. And so for every one new therapy that makes it to market, we probably started in early research synthesizing something like 10,000 molecules, maybe advanced 1,000 of them into preclinical safety studies. We had maybe 10 molecules that hit the clinic, of which 9 failed because there's still only a roughly 10% success rate. So a lot of room for improvement, all the while taking 10 to 15 years and a few $1 billion, everything included. So, how to summarize this? We can simply say new medicines take too long, they require too much investment, they fail too often or too late, and even when they succeed, they often don't reach the patients optimally that they should be doing. So we can project this onto the pharma pipeline and pharma process, but ultimately, right now at least, this is all still done by actual real-life living people. And again, let's take a look under the hood to understand who could actually use and benefit from ML in the context of drug discovery, development, and health. So, if we jump in to discovery and start with disease biology, when finding a target for an indication, you're combining literature, pathways, experimental assay data, real-world evidence. ML is well suited to bringing these together. And what I like to point out is that choosing an indication is not just a do once sort of thing. Therapies are often tried in multiple indications or with multiple combinations, different molecules, and this is constantly revisited along the way. So any way to augment this, would really de-risk these trials. Next is designing and optimizing the therapy. So easiest, I think, to think about small molecules. We have mountains of chemical assay data. The question is, can we enable our medicinal chemists to make better decisions, come up with better unbiased ideas, and arrive faster at an optimal molecule? Here it's worth pointing out that if you had better clinical or preclinical safety models from a different domain, you could bring this back as constraints into this process. And again, breaking silos. And so now, if we continue on towards clinical development, clinical trials, I think there's 3 main things First, historical patient data can help us understand what an ideal patient looks like, as far as, progression and response prediction models to know who should be in these trials specifically. Second, I think historical trial protocols and trial outcomes from like FDA.gov. This can help de-risk the clinical plan, better optimize our operational decisions, such as where to open a site, and even interdependencies between the two, i.e., how can a biomarker-driven inclusion-exclusion criteria affect our recruitment timelines and site decisions, again, breaking silos, as we brought in the previous talk. And last in development, I think, simply ML enables us to better quantify disease through innovative endpoints, digital endpoints, composite survey endpoints, and that improves everything from confidence in decision-making to a more holistic look at therapy, including patient quality of life and health system benefits, for example.